Hello, I'm John Cranham. I'm Clinical Director of the Dawson Academy and been a client here at Bayview for 25 years. And today I was asked to give my feedback or comments about triple tray impressions. You know, it's interesting that a lot of the clients that utilize Bayview aren't aware that they will do crowns on triple trays. And if you go into the lab and we look at remakes, the triple tray impression, when done properly, probably produces the least amount of remakes than anything we do. Now that might be because we are doing only 1 or 2 units at a time with it. But what I want to do in this little segment is to give you some tips on when I utilize this particular modality and how I've done so for a very long time with a high degree of predictability. First of all, understand the concept of a triple tray is that it does 3 things. It will go ahead and take the impression of the prepared teeth. At the same time, it will take the impression of the opposing arch, and will also capture the bite registration. And what makes the triple tray unique is it is a dynamic impression. Unlike when we impress one arch and then come back and impress the other arch, the triple tray, when done properly, when the teeth interdigitate, we actually account for the periodontal ligament. So teeth will intrude in the arch and we get a very accurate representation of what's going on in maximum intercuspation. So when do we utilize this? I tend to utilize it on my patients in the nuts and bolts part of my practice when I'm going to do a single unit or maybe 1 or 2 units. Patients that I've equilibrated and they're in centric relation and I'm just working maybe 1 or 2 units at a time in a particular quadrant. But the other time I utilize it is on patients that we've done a thorough examination. They have no signs of instability. There's no wear, there's no mobility, there's no migration, muscle issues or joint issues. And they may have a little slide, but we're deciding because of the lack of occlusal issues to build the patient in their own habitual occlusion, their maximum intercuspation. And so make no mistake, the triple tray does a fabulous job capturing the patient's existing bite. And so if you don't try to push this too far, you're going to have a high degree of accuracy with it. I also personally like to stay away from second molars with it, particularly on patients that may have higher occlusal type risks, wear, fractured teeth, and things like that. Because as soon as you prep that back tooth, you may have a little seeding of the condyle and it may not be quite as accurate. So the sweet spot for me in this is using a little tray like this for a first molar or a second bite. You can also get, excuse me, anterior triple trays if you're doing a single central or a lateral and working in that. Keep in mind that what this will do from a model perspective is it will create a situation where you're going to have less adjustment in max intercuspation if you capture the bite properly because of that the dynamic nature of how this is recorded. But because we're working in a quadrant, the lab really doesn't have the capacity to check excursions very well, particularly on the balancing side, because there is literally no cuspid on the other side to produce the non-working movement. The other thing is most of the time with a triple tray, we're not going to be mounting on a full semi-adjustable articulator. It's going to be a small articulator where the hinge axis isn't even close to where the patient is. So the way I think about this is that when I'm working with a triple tray, I'm going to have less adjustments to do in MI, but it's my responsibility to really look at the excursive movements and make sure that the patient clears both in working and the non-working side. The last thing I'll just say is with regards to taking a triple tray, giving you a couple tips with it. When you're utilizing this and you're squirting the impression material in the patient's mouth and then you're wanting them to bite on the triple tray, a lot of times when you get all that stuff in their mouth and they're numb, they don't know where their occlusion is. And what we will do, let's say we're doing the mandibular first molar here, we'll go ahead and mix our impression material appropriately. When we put the triple tray in the patient's mouth, I'll also have on a Miller forceps the articulating paper that I'll slide in on the other side, and I just tell the patient to bite on their back teeth. When they bite on their back teeth, what I want to make sure is I can't pull the articulating paper out. If I can't, then we have accurately recorded the patient's maximum intercuspation or their habitual occlusion. Let it set up, and then when you take it out, go ahead and hold your triple tray up to the light, and on either side of the prepared teeth, you want to be able to see the centric stops coming through the light, where the cusp tips are, the marginal ridge, wherever the patient is occluding, you're going to see that right through the tray. If you hold it up to the light and you don't, all you see is impression material and nothing come through, then the patient probably protruded and you haven't accurately recorded the patient's maximum intercuspation. That's critical with this. A couple other tips: you want to find a tray that is fairly loose. You don't want to have a real rigid tray. We want to use a tray that is easily movable and then a very rigid impression materials. Some of the people that are critical of triple trays are worried that when a patient bites on it, it can expand out and then snap back, which can lead to castings or restorations that don't fit properly. In my years using a triple tray like this that's fairly flexible and a rigid impression material like Imprint 3 or a polyether like Imprigum, I just have not seen that issue. I've seen very, very accurate fitting castings, and if we go ahead and have a hard model to be able to the lab to be able to check those interproximal contacts, we should be able to take that crown out of the box and it just drops in the mouth and it'd be very, very close. Like I said, the time that we spend may be working on the excursive interferences. So with that, I think if you choose your cases carefully, if you don't try to push the envelope too much on triple trays and have it just be there for the nuts and bolts side of your practice, I think you're going to find a high degree of success, as I have over the years.